Hello, everyone, and welcome to this audio podcast. This audio podcast is part of a research and report, and as part of a Labostix report, and as part of a ZtormLabostix production. In this and through this audio podcast, there'll be a look, sort of look at sort of works from in around 2017, where works was presented at the British Blood and Transfusion Society, BBTS, in around 2017, and where this works will look at the need to consider renal health through blood transfusion services to inform best practice. This audio podcast is a ZtormLabostix Collaborative. So a bit of an overview in the in around the contents of this audio podcast. So there'll be a look at an introduction, some aims and objectives. I look at what is CKD, or what is chronic kidney disease, and then I look at why consider renal health in all patients, and then look at clinical factors and decisions to transfuse, and then sort of looking at strategies for transfusion therapy, and specifically or particularly in around red blood cell transfusion, or RBTs. I look at leadership and management, and look at sort of a discussion conclusion, and then there will be an overview on citations or references at the latter end of this overview. So to begin with, looking at an introduction, there are no universally accepted treatment guidelines for managing transfusion care in patients with long-term conditions, or long-standing conditions, and/or chronic illnesses, or CIs, and practice tend to differ between hospitals, regions, and countries. Transfusion practices are developing, incorporating many novel pharmacological or pharmacotherapy agents into care in view of potential longer-term risk and side effects of RBTs, or red blood cell transfusions. There is at the same time ever more need to consider renal health specifically of patients who require transfusion care, especially since renal function is important in the synthesis of the hormone erythropoietin, or EPO, and where renal insufficiency is evident, there can be a difference between morbidity and mortality. To additionally inform that erythropoietin, or EPO, is a pharmacological or pharmacotherapy that has been routinely utilized or used or prescribed even in recipients or patients on different forms of KRTs, or kidney replacement therapies. Wherein there is evidence of low HB, low hemoglobin, and evidence of long-term misuse in around anemia. So now looking at sort of the aims and objectives. Number one, to provide a sort of practical context of leadership and management in transfusion care practices, transfusion care and/or practices. Secondly, to understand what further practical care is required for patients with long-standing conditions or long-term conditions and/or chronic illnesses. Thirdly, to highlight what practices would support the development of transfusion care guidelines. And fourth, to provide an understanding of treatment alternatives taking renal insufficiency into consideration. So to begin with, as part of the intro, if you like, to sort of help answer the question in what is CKD, or chronic kidney disease. So chronic kidney disease is a excuse me, is a long-term condition, long-term condition, or long-standing condition, and or chronic illness or chronic condition that can be summated as the steady and consistent reduction in renal function or kidney function over time, primarily in the disease development. Recipients or patients with CKD will have or may have no identifiable symptom or symptomologies, and it is largely a silent condition, and this has been the case this has been the case in amongst documented evidence and literature. And CKD is at the same time an underdiagnosed condition. Even in the absence of indicators, CKD adds significant burden on cardiovascular health, and can cause death acutely or even over time, owing to clinical manifestations. And CKD is thus now increasingly being sort of understood or recognized in amongst various parts of the world, in different countries, developed and underdeveloped countries, as a global public health problem, and is a sort of main determinant of poor health outcomes. There is more compelling evidence that disadvantaged communities, for example, those from low resource, racial and minority ethnic communities, and or indigenous and socially disadvantaged backgrounds, suffer marked increases in the burden of unrecognized and untreated CKD. And although the entire populations of some low and middle income countries could be considered disadvantaged, additional factors see a position of extreme disadvantage for certain population groups. For example, those living in some rural areas. Pediatrics and young people are diagnosed females or women, and also the elderly. And the fact that even in developed countries, CKD has increased, and outcomes suggest that there is much to learn beyond the traditional risk factors contributing to this irreversible chronic illness or condition and associated complications. Renal function is established by the degree of glomerular filtration rate (GFR) and or estimated glomerular filtration rate (eGFR). So now looking at why consider renal health in all patients. So from a practice perspective, practice perspective, this is actually a very important question that all scientists in transfusion laboratories should be asking routinely. And so considering the renal health and blood physiology of patients who may require red blood cell transfusions or RBTs is pertinent to achieving best practice, and more so now than ever, simply because CKD prevalence has been increasing, and patients with reduced GFR or eGFR or renal function renal function in amongst patients with a chronic illness or long-standing condition or long-term condition may require blood transfusion, for example, in cases where there are secondary complications such as hematological conditions and or following surgical procedures, which can have that can have a renal can sort of prompt or even predispose symptomologies around renal insufficiency over time. So with renal function decline, this has an impact on overall treatment and healthcare plans. Patients thus potentially becoming untransfusible, and the all-cause mortality rate in CKD is around 30 to 60 times higher than in the general population. Scientists and clinical teams need to question what are the clinical implications for transfusing. Additionally, what are the leadership management decisions required to transfuse safely, if at all. Now looking at a little bit in around the clinical factors and decisions to transfuse. So a better understanding of the risk of transfusion has transformed red blood cell transfusion medicine through the accelerated development of sophisticated donor laboratory procedures, thus improving infectious disease investigations, for example, pre-transfusion screening, and improvements in blood and component and improvements in blood component characteristics. So these developments have resulted in improved safety profiles for transfused components, for safety profiles of transfused components, and a perception of minimal risk. At the same time, the introduction of patient blood management or PBM is now defined as an evidence-based approach to optimize the care of patients who might need transfusion. The PBM approach has informed the need for transfusion. Has informed a need for transfusion and how it can be minimized. How minimized risk can be attained in many patients by implementation of thoughtful processes, often beginning days and or even weeks before actual decision to transfusion is made. Now looking at sort of the strategies for transfusion therapy. So although partial anemia correction with EPO stimulating formulations provide various advantages to normalize hemoglobin levels or HB levels, however, at the same time can be associated with cardiovascular and cancer risks. There is a general agreement or consensus that RBTs, red blood cell transfusions, are not typically indicated for hemoglobin levels of more than 100 grams per deciliter, and transfusion should be considered when HB or hemoglobin is less than 70 to 80 grams per deciliter, depending on patient symptomology. Quality monitoring for compatibility screening otherwise helps to ensure a high level of safety for patients receiving transfusion therapy, and it is important to note that lowering the hemoglobin threshold which blood is transfused can potentially reduce the need for a red blood cell transfusions. And this is not associated with increased morbidity or mortality amongst most critically ill patients. A more adverse effect of red blood cell transfusion RBTs have been highlighted in amongst documented and evidenced and published works. So now looking at managing anemia in the chronically ill recipient or patients. So reducing the number of inappropriate and borderline transfusion from around 80 to 30% reduces patient risk of adverse transfusion outcomes such as transfusion associated lung injury or TRI or TRALI and transfusion associated circulated overload or TACO, as well as transfusion formulation of antibodies, and so on. The need to include data on patient outcomes is paramount to truly appreciate the success of appropriate RBT prescribing. Presently, work has been outside the parameters of quality indicator or QI projects. In future, further audit and research into morbidity and mortality before and following guidelines would provide sort of pertinent information on patient outcomes. Sustaining the reduction would require ongoing works to highlight evidence-based data and work that may be both creative and cost-effective. Simple tools to aid clinical decisions can be invaluable, and research to understand and identify suitable alternatives and indications to RBTs for patients with LTCs, long-standing conditions or chronic illnesses have become more important, and especially surrounding clinical factors to appreciate renal health generally now needs a reputable standing. So looking at leadership and management, so there is still a need to appreciate further aspects of care required for patients or recipients with long-standing or long-term conditions and chronic illnesses, including CKD in a broader sense. And there is a need to highlight what specific practices would help in the development of transfusion care guidelines and a grasp of an understanding of treatment alternatives, taking into consideration again renal insufficiency, but from a leadership and management basis. An evidence-based recommendation for change in practice should include a more robust pathway to help support and develop future scientists, leaders, and managers, thus bringing practice more to the forefront. Healthcare scientists are required who can contribute through multidisciplinary MDT or MDT, for example, clinical and laboratory using evidence-based practices linked to literature, not just as standard operating procedures. This would shift the paradigm of leadership and management, wherein future transfusion specialists challenge the status quo to convince frontline colleagues. Managers also needed to prompt compassion through delivery of service and mentorship. So now looking at sort of the discussion, so scientists make decisions and interpretations based on a request in front of them, and by acknowledging how a clinical team might be caring for a patient in the short term. However, scientists should become more acquainted with pathophysiological parameters of disease to understand what forms of treatment would be best for a long-term trajectory uh, and 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 around transfusion care plans. All NHS trusts or National Health Service trusts need to feed into a main hub of what actual or of what works and what doesn't when it comes to transfusion care for patients with a long-term condition, long-term conditions, or chronic illnesses. And scientists also need to be involved in raising awareness and providing education to clinical and medical teams of the more intricate aspects of laboratory practice. There needs to be more studies or investigations in this subject, around this subject entity, so practices become more tailor-made for patients. And so, for example, phenotyping is one way that can help match patients can help match patients and rule out any sort of any sort of dangers in around antigens and antibodies, antigens and antibodies aligned to where renal function can be further compromised. Scientists who can highlight what treatment alternatives there are will help preserve can help will help and can help preserve renal function over time, and especially and where scientists are required or needed, especially those who know of the multifaceted nature of chronic kidney disease. Transfusion scientists should be having discussions and clinical having discussions with clinical and frontline colleagues, so they too are aware of advantages and disadvantages of RBTs, where patients' renal function can be or is compromised. So, in conclusions, scientists now have more active or proactive role to play with regards to informing frameworks and guidelines and contributing to laboratory practices, and specialists specialist interest groups or SIGs. Scientists with transfusion expertise and leadership aptitude are required to enhance the importance of understanding of renal health and sensitivity of laboratory investigations through multidisciplinary or MDT efforts. Modern laboratory practices are now extending leadership functions across departments and teams in most NHS National Health Service laboratories. Good leadership and management thus also requires input from colleagues at all levels to achieve consensus and help form robust renal transfusion guidelines. PBM or patient blood management again will become more important in transfusion practices. Thus care is now moving more toward patient centric approaches, almost similar to that of personalized medicine. In around 2014, the National Blood Transfusion Committee informed transfuse one dose of blood component at a time. For example, 1 unit of red blood cells or platelets in non-bleeding or those in non-bleeding patients in non-bleeding patients in non-bleeding patients, but wherein the hemoglobin or anemia or where anemia was evident as being less than 70 to 80 grams per deciliter, and where um, and where the hemoglobin where the hemoglobin count should be determined further should be determined subsequently to identify if further transfusion is needed. This should help management in suspect or high risk patients in suspect or high risk patients where renal insufficiency is where renal insufficiency is important and to be determined. So here is a slide where listeners and viewers can sort of pause and sort of look to refer to citations or references and identify works in regard to the outline of this overview, but also in regard to similar works in amongst the evidence and published works. That draws this audio podcast to a close. This overview as part of a research and report series. This audio podcast is part of a Labostix report. This audio podcast overview as part of a ZtormLabostix production.